This lesson is going to talk about HHNS. HHNS stands for Hyperglycemic Hyperosmolar Non-ketotic syndrome. So that actually gives us a bit of a hint as to what's going on, right? This is a state of hyperglycemia, except without ketosis. So it is considered an acute exacerbation of type 2 diabetes mellitus. Remember that the cell has two options for getting energy. One is glucose, the other is fatty acids, and both of those will end up producing ATP or energy. In order for the cell to use glucose, it has to have insulin, and the production of energy by fatty acids produces ketones. In DKA, we saw that this entire process was lost, and so they had to go this way. The difference here is in type 2 diabetes mellitus, they have just enough insulin here to actually prevent this process from happening. So what we see is they have just enough to get the mandatory amount of glucose, but not enough to manage the high levels. So we're going to see extreme hyperglycemia because they still don't have enough insulin, but we're not going to see this ketoacidosis. Now, this is usually a gradual onset, and it can also be triggered by infection, stress, or dehydration, or by them not taking their meds or just making poor choices. So what we're going to see in HHNS is that these patients' blood sugars are at least over 600, but honestly, the average is like 1,100. I had a patient just the other day. His was 1,303. They tend to be very, very high blood sugars. Now, the big thing you'll notice here is they're much higher than what we see with DKA, which is usually like 600 or less. Why is that? Honestly, it's because these HHNS patients don't have acidosis. Once that acidosis hits in DKA, those patients start to feel really sick and they don't feel well and they go to the ER. In HHNS, they may feel tired or they might be extra thirsty, but since there's no acidosis, their sugars just keep going higher and higher and higher before they even feel sick enough to need to be seen. So remember that in HHNS, they're going to have extreme high blood sugars, negative ketones, but they'll still be dumping the sugar into their urine because the sugar is so high. Fun fact, the threshold for glucose dumping into the urine is 180. So anything over 180 is going to dump into the urine. When that happens, we see that osmotic diuresis. So it dumps sugar and the water follows. So we're going to see this polyuria, okay? So we're still going to see this dehydration. So that's the biggest issue we see in HHNS is this hyperosmolarity and this profound dehydration. Remember, with all that extra blood sugar in the bloodstream, those fluids are going to shift out of the cells. So you have all this blood sugar, it's super concentrated, fluid's going to shift out of the cells and it's going to shrink them up. So you're going to see this severe dehydration. Since the sugars tend to be much higher in HHNS, this osmotic shift is even more severe and the dehydration is much more significant in HHNS than it is in DKA. They're going to have dry mucous membranes. They'll likely have an elevated temperature. And they'll probably have an altered LOC because of that severe dehydration, okay? That causes confusion, lethargy, and honestly, what happens is they start acting funny, and that's what brings them into the ER is their family saying that they're acting funny. They could even go all the way into a coma. And then, of course, because of this severe dehydration, the stress on the kidneys, we can also see their BUN and creatinine elevate. So just like DKA, of course, we want to identify and treat the cause, especially if it's infectious. We want to make sure we're managing that. But our top priority in this case is going to be replacing those IV fluids. The dehydration, the osmotic diuresis is profound in HHNS. So replacing lost fluids is the most important thing we can do. That patient I had who had a blood sugar of 1303, we gave him 3 liters of normal saline, and within 2 hours, his blood sugar was down to 825. with no insulin therapy, just fluids. This makes a huge difference for these patients. However, a lot of them are still going to need some insulin therapy. So we're going to give them either regular insulin IV with intensive insulin therapy, or we could just start them on a high dose sub-Q regimen, like with Novolog. It just depends on the patient. But when it comes to, let's say, NCLEX questions or nursing school questions, you're going to see something like start 2 large bore IVs. Y'all, this is definitely a priority for these patients because we know that our number one goal is to replace these fluids. Now, of course, we want to monitor neurostatus, monitor electrolytes. Again, insulin can drive potassium into the cells and they could actually become hypokalemic. So we want to make sure we're considering replacing their potassium if necessary. Now, DKA patients may start hyperkalemic and move down because of the acidosis, but HHNS patients aren't acidosis, so they're going to start normal and go down much faster. So potassium is a bigger issue in HHNS than it is in DKA. So we're usually going to check chemistries every 2 to 4 hours on these patients, and we can always add potassium chloride to their fluids if necessary. Okay, our top nursing concepts for a patient with hyperglycemic hyperosmolar non-ketotic syndrome, or HHNS, are going to be number 1, fluid and electrolytes, number 2, glucose metabolism. Fluid replacement's number 1, insulin is number 2. Make sure you check out the care plan attached to this lesson to see those detailed nursing interventions. Okay, let's recap. In HHNS, there is hyperglycemia and hyperosmolarity, but there is no acidosis and no ketones because the body has just enough insulin to prevent that process. We'll see this severe hyperglycemia leading to glucose being dumped in the urine and causing this hyperosmolar state. This leads to osmotic diuresis and a profound dehydration, worse than any other situation you'll see. Patients will be dry and hot, and they'll possibly have an altered LOC. They'll be confused and lethargic. Our number 1 priority is to correct that dehydration, replace those IV fluids, and then, of course, we'll give some insulin therapy to get their sugars down and monitor and replace their potassium as needed. So those are the things you need to know for HHNS. You can kind of see how DKA and HHNS are similar, but the priorities are different. So if you haven't watched the DKA lesson, check that out as well. Don't miss all the resources attached to this lesson, including a cheat sheet on the differences between DKA and HHNS. Now go out and be your best selves today, guys. And as always, happy nursing.